is our presentation on catheter-associated urinary tract infections in post-orthopedic surgical clients. I'm Emma.
My name's Amanda.
I'm Julie.
Trevor.
Chandra.
All right, so we're just gonna start off with a couple definitions. To start, what is an IUC? It is an indwelling urinary catheter. It is a flexible little tube that goes into the urethra, leads up to the bladder, and is held in place by a little balloon, as you can see in this picture here. It's often used for urinary retention, long surgeries, incontinence, immobility, or strict I&O measurements. It is intended for short-term use because there is a major infection risk like CAUTIs. So what is a CAUTI? It is a catheter-associated urinary tract infection. It is the most common healthcare-associated infection, and it occurs when bacteria is entered into the urethras, into the urinary system, which can eventually lead up to the kidneys, causing sepsis because the urinary system is a sterile system, so it is a sterile procedure, and the introduction of bacteria can be deadly.
And because it's so serious, it's important to understand risk factors such as increased age, the elderly, immobility, urinary stasis, improper sterile technique, or the introduction of bacteria to the system. How can we prevent this? So some of the care and interventions include proper maintenance of the line, ensuring it remains in place, that it's cleaned properly, that it's regularly drained, it's in a proper position below the level of the bladder, that pericare is performed, sterile technique is utilized in placement, and there is proper assessment with removal.
Nursing plays a central role in reducing catheter-associated urinary tract infections. They do this by leading and driving protocols, implementing the CAUTI bundles that are set post-surgery, monitoring device utilization ratios and quality improvement, providing education to staff and patients, and documentation and compliance, and causing the systemic impact.
CNAs play a supportive and assistive role in that they help record I&O with draining the bag. They report concerns with the patient and anything that they may observe, like discolored, foul-smelling urine, those kinds of things, to help the nurse better assess and intervene.
Much like the nurses and CNAs, there are a couple other roles on our interdisciplinary team for these patients. So for starters, we have the orthopedic surgeon. Their role is much less indirect than the nurses and CNAs, but it's still very critical. They are there to help limit catheter use. They are the ones that put the orders in to insert and discontinue the catheter. They help with balancing mobility and retention, such as early ambulation, and they coordinate all of their care with the rest of the healthcare team.
We also have the pharmacists, which they're involved in managing the patient's prescribed medications, either home medications or hospital newly prescribed medications. They review any meds that may increase urinary retention. They monitor the use of opioids or narcotic medications. They ensure appropriate antibiotic therapy. And they collaborate with the physicians and nursing staff to manage any kind of polypharmacy that's happening with the patient.
So in post-orthopedic patients, as Emma mentioned, the goal is to try and get that catheter out as soon as possible, but unfortunately some of these patients might have long surgeries, especially to monitor their output, to make sure that their kidneys are functioning well. After surgery, a lot of these patients are immobile, they have restrictive movement, and they really want to reduce the strains on any repairs that they have. They also have spinal and epidural anesthesia, and it blocks the bladder sensation, which can also cause post-operative urinary retention or POR. Why are these patients at risk for CAUTIs? As mentioned, they have delayed ambulation, so there's a great concern for falls, and they just want to keep that fully in until they're able to use the bathroom by themselves. Lots of these ortho patients are usually older people, so they just have a weakened immune system, and medications also have effects on them, such as opioids. They can cause retention, and the sedatives can decrease the awareness of that bladder sensation. Some specific complications of CAUTIs with these ortho patients, the infection increases weakness, fatigue, and confusion, which delays their rehab process. It slows down the recovery time and increases their length of stay. As Emma mentioned before, the bacteria can spread. It can also spread through the bloodstream, and it leads to prosthetic joint infection, which just delays the process even further. And they can end up on long-term antibiotic use, which causes other complications, such as antibiotic resistance, C. diff, any other problems with antibiotics.
Okay, so there's some alternatives to using Foley catheters. We have the straight catheter, which is used for urinary retention, sterile urine specimen collections, or a neurogenic bladder or spinal cord injury or surgery. The next three, we have a PureWick, that's for females, a male condom catheter, and the external male catheter. So as in the name, they're all external catheters. These can be used for urinary incontinence, post-surgery spine hip femur, when these patients are not able to get up and ambulate. It helps prevent skin breakdown from urinary incontinence, prevents falls due to any nocturia, and they're non-invasive, so lower risk of infection compared to Foley's.
So this whole presentation is related to CAUTIs and implementing a nurse-driven protocol to help reduce catheter utilization and CAUTI rates. So a nurse-driven protocol allows for qualified nursing professionals to have autonomy in their specific areas of practice. It improves patient safety, it improves staff satisfaction, and it increases the effectiveness of care. So in this scenario, our nurse-driven protocol is to have the ability to discontinue catheters without a physician's order or using a standby order based on the nurse's clinical judgment.
A couple barriers to nurse-driven protocols. Autonomy hesitation. A lot of units have a wait for the doctor kind of culture. This kind of makes the nurses lack clinical confidence, and they don't want to act independently without having physician buy-in. And then convenience is another big one. So a while back, catheters were actually used for convenience. And I think a lot of nurses still to this day use it for convenience. When a patient has a Foley, they'll either knowingly leave it in for convenience of the patient and the staff, or subconsciously maybe just push off the removal till the next shift. Either way, this leads to higher infection rates. Costs associated with nurse-driven protocols. For these protocols, you have to pay for the education, the supplies, employees' time for being trained, and not all facilities in the US see this as a standard practice. So cost plays into nurse-driven protocols quite a bit. And another huge one is physician pushback. A lot of physicians will bypass the nurse-driven protocol by writing "do not remove" orders. And then this stems from a lack of confidence in nursing clinical judgment, as well as some physicians like to have strict control over their patients and any procedures that their patients may have. Couple study results. We'll talk about these studies a little more, but this one specifically found that the nurse-driven protocol significantly reduced the CAUTI risk by 55.9% and lowered the catheter utilization ratio from 49.4% to 34.8%. This next study includes CAUTI incidence dropped by 73%. Notably, nursing compliance with the removal protocol, Houdini, we'll talk about that as well, improved from 56% to 93%, which is great.
Some more research studies that we have found based on the nurse-driven protocol are listed here. Both of these utilized a nurse-driven protocol. This one specifically, they use the Houdini protocol, which we will get into. But basically, in this one, their CAUTI rates decreased from 1.36 to 0.32%. And then in this one, their CAUTI rates dropped to 0 with the previous baseline of 4 per 1,000 catheter days. So Houdini is an acronym. It stands for hematuria, obstructed urologic surgery, Debiticus ulcers, input-output monitoring, not for resuscitation or end-of-life care, and immobility due to physical restraints. So this is the criteria that a client has to meet in order to keep the indwelling catheter going. If they do not meet this criteria, then they are in the clear to get their catheter removed. So it helps with CAUTI prevention because it decreases CAUTI rates, device utilization, and catheter duration. It allows nurses to lead in the removal of these catheters through the use of evidence-based checklists and critical thinking. And then the checklist is used every shift, so twice in 24 hours, to determine the necessity. And then notably, the nurses have a note that they're required to make to document that they have evaluated the indwelling urinary catheter appropriately according to the Houdini protocols.
So with all of this, PT and OT is involved. PT mainly focuses on early mobilization, and they want to ensure that the activities the patient is doing does not dislodge their catheters. The end goal is to achieve safe mobility, especially to the bathroom, so that they can get that catheter out as soon as possible. OT works with the patient to manage the tubing while they're performing their ADLs, so that includes getting dressed, getting up, going to the bathroom. PT and OT often work simultaneously, and it reduces the length of stay, it reduces the risk of infection and other complications. They're also working with the nurses and communicating with them, letting them know how the patient is progressing to see if they can get that catheter out soon or not.
The implementation plan, staff education on Houdini criteria, the EHR prompts for daily catheter necessity, standing order authorizations for the RNs, and then we do a monthly tracking of number of catheter days, CAUTI rates, recatheterization rates, and then feedback loop between the staff and the leadership team. Post-removal monitoring. So for the first 6 hours, nurses and CNAs are encouraged fluids, assess for voiding every 2 hours, and then bladder scan if there's no void within 6 hours. And then they notify the provider if the PVR is greater than 400 mils, there's no voiding within the 6 hours, or there's signs of retention.
Just some references that we use to create the presentation. And that is it. Thank you.
Thank you.